Hi, I am Dr. Selvaraj, Professor of Surgery, Malakka Manipal Medical College, Malaysia. Welcome back to my series of surgical teaching videocasts. These are meant mainly for undergraduate medical students doing the surgical flux hip rotation. I promise you will become competent in clinical problem solving and surgical decision making if you are going to watch these videos over and over again. In this episode, I am going to talk on one of the very common topic in general surgery, the hemorrhoids or the piles. So I am going to talk under the following subheadings. I am going to talk on the different causes of lower GI hemorrhage, the etiopathogenesis of hemorrhoids, classification of hemorrhoids, clinical features, investigations, complications, and treatment of hemorrhoids. Of course, I am going to include a mind map and a diagnostic algorithm and a management algorithm. So what are the different causes for lower GI hemorrhage? The diverticular disease and the angiodysplasia or the AV malformation. Usually the bleeding will be very profuse and it is a spontaneous bleed, not associated with straining or associated with defecation. Whereas all other bleeding, especially the hemorrhoids and fissure in ano, usually this is associated with straining or after passing stools, or these bleeding in hemorrhoids and fissure in ano both are post-defecatory. So other causes are colorectal carcinoma, inflammatory bowel disease, and Meckel's diverticulum. Of course, the very profuse severe upper GI hemorrhage can also present as hematochezia. So this is our classical clinical vignette. Our patient is a 72-year-old man with history of chronic constipation, presented with bright red blood per rectum after straining to pass stools each time for the past 3 months. Bleeding was painless. It was painless hematochezia. Colonoscopy 6 months ago was normal. On examination, his vitals were stable. BP was 150 by 70 millimeters of mercury. Heart rate is 90 per minute. The PT, PTT and INR are normal. Platelet count is also normal, and the INR is also 1.1, that is within normal limit. The proctoscopy, it revealed primary hemorrhoids at 3, 7 and 11 o'clock position. So the diagnosis is straightforward. It is a case of internal hemorrhoids. There is an altered scenario apart from the bright red blood per rectum during straining to pass stools. Patient is presented with also anal itching and discomfort, particularly towards the end of the day, and he has perianal pain when sitting down and finds himself sitting sideways to avoid this discomfort. Of course, the patient is afebrile. So this is a case of external hemorrhoids or a case of prolapse internal hemorrhoids. So coming to the etiopathogenesis, hemorrhoids are normal cushions of submucosal tissue that contains venules, arterioles, and smooth muscle fibers and elastic connective tissues. 3 hemorrhoidal cushions are there normally at 3, 7 and 11 o'clock position, because the right superior rectal artery has got 2 branches, whereas the left artery is only 1 branch. That is why you are having 1 at the left side and 2 on the right side. During defecation, these cushions become engorged with blood. This will cushion the anal canal and it will support the lining of the canal. Hemorrhoid is a condition where there is varicosity of the veins of the anorectal region, which subsequently this leads to hemorrhage. So this is a normal. You are seeing this is the internal hemorrhoid, which is above the pectinate or dentate line. This is internal hemorrhoids, and this is external hemorrhoids without any prolapse. Whereas here the internal hemorrhoid start prolapsing outwards. Yeah, this you will get exactly at 3, 7 and 11 o'clock question. These are called primary hemorrhoids, and in between these 3, 7 and 11 you will get minor hemorrhoids also. So coming to the exact cause, it is idiopathic or it's called primary. So the predisposing factors may be the pregnancy or prolonged standing, etc. The secondary causes, usually there will be some underlying pathology like carcinoma of the rectum that will block the veins, that will produce the back pressure, and that will manifest as the hemorrhoids, or prolonged constipation or persistent straining at micturition because of BPH, that also can produce hemorrhoids. So what happens? This is the normal anal cushion. This is a normal thing, while this a normal thing is the rectal junction is closed by this sphincter, internal sphincter, and then external sphincter, and this cushion is also, this is the anal cushion, or these are the hemorrhoids. While the patient is passing a hard stool, okay, this sphincter relaxes. So this hard stool will go through this, this anorectal junction, and this will compress the hemorrhoidal cushions. And this will also scratch, if it is very hard stool, this will scratch the mucosa, and that will produce some injury to this anal cushion. So after passing this hard stool, the patient will start dripping blood from these hemorrhoidal cushions. So after this, the next stage is the sphincter. The sphincter will close. So these hemorrhoids should retract inside. Suppose if it is not retracting inside, okay, this venous return will be blocked, and the patient will result in splashing of the blood into the toilet pan. So this is how the bleeding happens in hemorrhoids. So coming to the classification of the hemorrhoids, okay, it is called internal hemorrhoids if it is lying above the pectinate line or dentate line. It is external hemorrhoids if it is situated below the dentate line. If it is situated both above and below the pectinate or dentate line, it is called interno-external hemorrhoid. So here you are seeing this is internal hemorrhoids and this is external hemorrhoids. Okay, this internal hemorrhoids is now prolapsing outside. So this is external hemorrhoids. So this is what you are seeing in this picture also. This is the different stages or different degrees of hemorrhoids, where in the first degree hemorrhoids there is no protrusion of the hemorrhoid at all. In the second degree of hemorrhoids, the hemorrhoid will prolapse outside and it will get automatically or spontaneously, it will get reduced. In the third degree hemorrhoids, okay, it will get prolapse, but it needs manual reduction for it to get reduced. Whereas in stage 4 or the fourth degree hemorrhoids, okay, it will get prolapse, but even manually you cannot reduce. It becomes irreducible. That is the fourth degree hemorrhoids. So coming to the clinical features, okay, the commonest thing is the bleeding per rectum. That is bright red blood per rectum. This bleeding is usually painless, and the patient will, this appears as the fresh smear on the toilet paper. Pain is not a characteristic feature of hemorrhoids unless it is associated with fissure in ano or thrombosis of these hemorrhoids. Strangulated hemorrhoid is also will become extremely painful. There will be mucus discharge if in case of third and fourth degree internal hemorrhoids and in external hemorrhoids. Pruritus ani will be also there in cases of third and fourth degree internal hemorrhoids and in external hemorrhoids, because this mucosa will be prolapsed outside and that will produce the itching sensation around the anus region. And the patient also will be having tenesmus, that is sensation of incomplete evacuation of the bowel. This is also one of the symptoms in hemorrhoids. So here you are seeing the different degrees of hemorrhoids. This is, you are seeing a proctoscopy or anoscopy where you are seeing a bulge inside. This is first degree hemorrhoids. In second degree hemorrhoids, while the patient is training or to pass stools, okay, the hemorrhoids is prolapsing outside, but it will get reduced spontaneously. This is second degree hemorrhoids. Whereas in third degree hemorrhoids, okay, here also while the patient is training, okay, the hemorrhoids is coming out, but it needs manual reduction to get it reduced. Whereas in the 4th degree hemorrhoids, even manual reduction is not successful, it becomes irreducible. Here in this picture, you are seeing a thrombosed external pile mass. This is not associated with internal piles, so the external piles becomes thrombosed. This is one of a very, very painful condition. So coming to the investigation, okay, you can do a digital rectal examination, but you cannot palpate this pile mass because these are all compressible things. But you can palpate this hemorrhoid if it becomes thrombosed. But the diagnostic test is you must do proctoscopy or anoscopy to confirm your diagnosis. You will be seeing the primary piles or hemorrhoids at 3, 7 and 11 o'clock positions. That you can see by using a proctoscopy. But of course, if you are seeing a hemorrhoid, you have to rule out any other pathology in the proximal part of the colon by doing sigmoidoscopy and colonoscopy to rule out any other colonic pathology. So coming to the complications of the piles, okay, because of the severe bleeding, severe and continuous bleeding, patient may go for anemia. And sometimes, okay, this will go for strangulation. This occurs when the prolapsed hemorrhoids are gripped by the internal sphincter and it gets irreducible. That is very common in 4th degree hemorrhoids. Thrombosis is another complication. In strangulated hemorrhoids, the venous return is occluded and thrombosis occurs. Thrombosis is accompanied by very, very severe pain. Sometimes, okay, suppuration and ulceration also can happen in this prolapsed hemorrhoids, and this may occur in a prolapse and thrombosed hemorrhoids. Fibrosis, after 2 to 3 weeks, these thrombosed hemorrhoids become fibrous, and often this will result in spontaneous cure. Coming to the treatment, to begin with, especially for 1st and 2nd degree hemorrhoids, you can do what is called non-operative treatment. You can give sitz bath. The patient is asked to sit in warm water or lukewarm water with the anal region and buttocks dipped in the water for about 20 minutes, 2 to 3 times a day. This reduces the pain, edema, and this also promotes healing. You can also give some antibiotics, especially if you feel that the piles or the hemorrhoids is infected. You can also give laxative or stool softener, and you can also try anti-inflammatory drugs. All these are supportive treatment. You can also advise the patient to take high fiber diet so that the patient will get relieved of constipation. You can also go for local application of some astringent ointments. You can go for injection of sclerosants, especially the commonly used thing is the 5% phenol in almond oil. You have to inject over the hemorrhoidal mass, internal hemorrhoids, for 1st and 2nd degree. So coming to the operative treatment, for 1st and 2nd degree hemorrhoids are treated by either Lord's procedure, Barron's band application, and cryosurgery. The 3rd and 4th degree hemorrhoids should be operated, that is hemorrhoidectomy, either open or closed hemorrhoidectomy. So Lord's procedure, usually in US they are not doing this Lord's procedure, but in UK they are still doing this Lord's procedure. Under general anesthesia, the internal sphincter is widely stretched. It results in dilatation and disruption of the fibers of the internal sphincter. Thus, the venous congestion is relieved to improve the hemorrhoids, but this will result in unnecessarily prolapse of the hemorrhoids. So the other method is the Barron's band ligation. This you can do for 1st and 2nd degree hemorrhoids. This is because this you must do only for internal hemorrhoids, because internal hemorrhoids, if you apply the band, it will be painless. If you are going to do the Barron's band for external hemorrhoids, it will be very, very painful. The patient will be cursing you. So you have to do only for internal hemorrhoids. So here you are seeing the injection sclerotherapy. You are using the phenol in 5% phenol in almond oil. You have to take this Gabriel syringe. You have to inject it. You have to use a anoscopy. You have to inject into the pile mass. This is for internal hemorrhoids only. And this is the Barron's banding. You have to catch hold of the internal hemorrhoid, and this is the band. This you have to apply over the pedicle of this hemorrhoid. So this hemorrhoid will become necrotic and it will fall off. So coming to the other operative treatment, cryosurgery is another method. Liquid nitrogen at minus 190 degrees Celsius is applied to the hemorrhoidal masses which coagulate the tissue, but this cryosurgery will the healing will be prolonged, and there will be a lot of discharge from the operated area. So nowadays we are not doing cryosurgery. The another method is infrared photocoagulation. This you have to apply this infrared rays just above the hemorrhoidal masses that will coagulate the tissue protein, or it evaporate the water in the cells. Ultimately, that blood supply to the hemorrhoidal plexus will be obliterated, and this also is not this also required several sittings. So this also is not in vogue now. So the other actual surgery is hemorrhoidectomy. This you can do either the open hemorrhoidectomy, which is called Milligan and Morgan's open hemorrhoidectomy, or the Fergusson's closed hemorrhoidectomy. So here you are seeing the cryosurgical method. You have to use this liquid nitrogen that will freeze the tissue there, but nowadays we are not using it because the healing is prolonged and there will be quite a large amount of discharge from the wound. So nowadays we are not doing this one, and this is the infrared coagulation. You have to apply the infrared rays just above the hemorrhoidal tissue, and both these techniques we are not doing, not in vogue now. And this is the real operative surgery. This is the closed method where you have to put the patient in lithotomy or lithotomy position, and then you have to, or jackknife position. So you have to put a retractor in the anal canal, and then you have to excise it from internal side over the mucosa, anal mucosa. You have to excise the pile mass, and then you have to ligate it. Then you have to close this suture, this mucosal raw area. You have to suture it. That is why it's called closed hemorrhoidectomy. Whereas in Milligan and Morgan's method, okay, you have to expose the pile mass. You are seeing it at 3, 7 and 11 o'clock position. You have to make the skin incision, a V cut over the external skin margin like this. Here you have to make a cut. You have to go inside, and then you have to put a transfixation suture at the hilum of, or the pedicle of this hemorrhoidal plexus. Then you have to cut this excessive tissue, and there will be a raw area. Ultimately, there will be a raw area in the skin and in the mucosa. So ultimately, you have to leave a skin bridge in between these raw areas. So if you are seeing, if this is like a clover, if it looks like a clover, the problem is over. This is what they are saying. If it looks like a dahlia, so it is surely a failure. So what will happen if you are not leaving this skin bridge in between these raw areas? Okay, ultimately the patient will go for anal stenosis. So you have to leave these skin bridges. That is very important in this open method of hemorrhoidectomy. So the other, nowadays the latest trend is you can do what is called a staple hemorrhoidectomy, or this is also known as procedure for prolapsed hemorrhoids, or PPH. So you have to introduce a cannula here, the obturator, you have to remove it. Then you have to put a pursing suture above the dentate line. Then you have to put this stapler inside, pull the mucosa along with the submucosa. When you are taking this pursing suture, you should not take a very deep bite. We are supposed to excise only the mucosa and the submucosa along with these hemorrhoidal plexus. So when you are taking this pursing suture, you should not take very deep sutures. You should not include the musculature there. So after putting the stapler inside, this is the anvil. Anvil should be above this your pursing suture. Then you have to tighten the this stapler. So you have to pull this pursing suture, and then you have to tighten this. So ultimately you will be cutting this excessive mucosa just above the dentate line and above this hemorrhoidal plexus. So the prolapse hemorrhoids will go into its normal anatomical position, and this instrument, this stapler, will make a circular cut, and then the anastomosis also will be there. You can see that staple line. So the only precaution is when you are taking this pursing suture, you should not take a deep bite. This is also a painless procedure. This is what is gaining popularity nowadays. And another latest method is ultrasound guided hemorrhoidal arterial ligation. So this you can do. You can put a this instrument inside, and this is the ultrasonic transducer. This will pick up this hemorrhoidal artery. So you can insert a instrument through this window, ligature window, and you can ligate this hemorrhoidal artery. And this is also gaining popularity nowadays. So this is the mind map for hemorrhoids. Etiology, it is idiopathic, that is the primary. The causes are either pregnancy or prolonged standing. Secondary, usually associated with some underlying disease or pathology. Maybe it is prolonged constipation or CA rectum. Classification, first degree hemorrhoids, there is no protrusion or prolapse outside. In secondary degree hemorrhoids, there is prolapse with spontaneous reduction. In third degree hemorrhoids, there is protrusion or prolapse that needs manual reduction. In fourth degree hemorrhoids, the protrusion becomes irreducible, or even manually it is not reducible. Clinical features, the most common thing is post-defecatory bright red blood per rectum. There may be mucus discharge in third and fourth degree internal hemorrhoids and in external hemorrhoids. And the same in third and fourth degree internal hemorrhoids and external hemorrhoids. The patient will also have pruritus ani because of a massive mucus discharge. Okay, they will have pruritus ani or itching around the anus. Patient may also have tenesmus or inadequate sensation of evacuation of the rectum. Pain may be there if the hemorrhoids become thrombosed, especially in external thrombosed hemorrhoids. Investigation, the investigation is you must do a proctoscopy or anoscopy, that is diagnostic. Of course, you can do a digital rectal examination to rule out any rectal pathology, or you must do a colonoscopy or sigmoidoscopy to rule out any other associated colonic pathology. The complications are if bleeding is prolonged, okay, the patient may have anemia. The hemorrhoids may become irreducible in fourth degree hemorrhoids, and it will go for strangulation. It will get also thrombosed, and sometimes it may get suppurated, and ultimately it will get ulcerated also. If you are not going to intervene, ultimately it will get fibrous, and spontaneously it will get sure also. That is also a possibility. The treatment is for first and second degree hemorrhoids. Okay, you can try non-operative treatment like sitz bath and laxative, or you can go for injection sclerotherapy, that is 5% phenol in almond oil, that you can try, or you can do a Barron's banding. This should be done only for internal hemorrhoids. You can also try infrared coagulator and cryosurgery. Both are not in vogue at present. Or you can do, if it is a third and fourth degree hemorrhoids, you can do hemorrhoidectomy, either open or closed method. The closed method is Ferguson's method. The open method is called Milligan and Morgan's method. Or nowadays we are doing staple hemorrhoidectomy or procedure for prolapse hemorrhoids, and the another one is ultrasound guided hemorrhoidal artery ligation. These are the different treatment modalities available for hemorrhoids nowadays. So this is the diagnostic algorithm for lower GI bleed. If the patient is having rectal bleeding and you have to do the history and physical, if it is a bright red blood, you can do a proctoscopy and sigmoidoscopy. So you can pick up either it may be a rectal cancer, polyp, or hemorrhoids or fissure in ano. Suppose if the proctoscopy is normal, then and the bleeding is also very dark blood, then you must do a colonoscopy or sigmoidoscopy, where you can pick up a colonic polyp, angiodysplasia, or diverticular disease, or you can pick up inflammatory bowel disease and other pathologies. So if the dark blood is associated with massive bleeding, then you have to rule out any upper GI bleeding also, because massive upper GI bleeding also can present as bright red blood per rectum, that is hematochezia. So you must rule out upper GI bleeding by doing you can do a NG aspiration, or you can do a OGD, or you can do a angiogram, or RBC tag scan you can do. So you can be knowing exactly what it is. Angiodysplasia and all these things, Meckel's diverticulum, all these things you can pick up by doing these investigations. So this is the treatment algorithm. So hemorrhoids, you have to do a thorough history and physicals. The commonest cause is constipation, and the patient will present with bright red blood per rectum, and you must do a rectal exam, you must do a endoscopy, and you must do a sigmoidoscopy and colonoscopy also. Hemorrhoids may be external. If there are skin tags, just you have to observe. If you are having a thrombosed external pile mass, okay, if it is a early case presented within 4 to 5 days, then you have to excise the excise the thrombosed pile mass completely. If the patient is presenting to you late, that means more than 5 days duration, you have to just treat the patient symptomatically. If the patient is having internal hemorrhoids, if it is first or second degree, you can treat it conservatively with medical management. If it is a success, okay, that is it. If it is not amenable to the medical treatment, then you can go for rubber band ligation or infrared coagulation, or bipolar coagulation and ultraroid. These two things are also not in vogue because the bicap and ultraroid are very expensive. Or you can also go for sclerosing agent, that also you can try. Suppose if it is third degree or fourth degree hemorrhoids, okay, you can do either a open or closed hemorrhoidectomy. If it is a strangulated hemorrhoid, that is the fourth degree hemorrhoid with strangulation, don't do surgery immediately. You have to treat it medically. That means you have to treat it with anti-inflammatory drugs. You reduce the inflammation and the edema, and then you do hemorrhoidectomy. Suppose in special circumstances, patient is pregnant, don't do surgery. If patient is having portal hypertension, don't do surgery for hemorrhoids. If patient is having inflammatory bowel disease, you can do surgery in ulcerative colitis, but don't do surgery in Crohn's disease. If patient is HIV positive, that also has to be dealt with like an Crohn's disease. Don't do surgery in HIV positive patients. So thank you very much for watching this video. If you think that these videos are very useful, I request you to do 3 things. You like, just click the button, the like button for this video. You share this video with your friends, and then so far, if you have not subscribed for this channel, kindly subscribe for this channel. Thank you once again for watching this video. Bye bye until we are going to meet in yet another video. Bye.